and all others, I people are able to listen to me clearly?
Yes, it's clear, sir.
Good. So we are starting our today's session. Bismillahir Rahmanir Rahim. This session is basically quite delayed, and I was planning to do this session on PACES 23 earlier. Because of some responsibilities and some unavoidable circumstances, I was unable to deliver that lecture because, of course, we are really close to PACES 23, and hopefully this will be fully implemented in DITE 3. And it is really important for the candidates to know exactly what are the changes, what they are bringing, and how you can deal with all the relevant challenges. Especially, it was creating some apprehension in those candidates which are already preparing on the current PACES scenarios and the current PACES pattern. So today I am planning to rectify all these problems, all these concerns. Now we will divide today's talk in three parts. In the first part, I will try my level best to elaborate what exactly is now the clinical consultation in PACES 23. We will be focusing more today on clinical consultation station of PACES 23. Yeah, might be next week or might be next to next week, we will be planning a session on clinical communication according to new PACES pattern also. The second part of this presentation, this talk will include a scenario, which is a really high yield scenario according to the newer clinical consultation pattern, and the candidate will perform in front of you. Third part of this today's talk will include question answer session, and I will try my level best to dedicate might be 5 to 10 minutes for question answer sessions. So, Dr. Jason, please keep your mic unmuted because might be my voice is getting low. So anytime if my voice is getting low, there's some connection problem, please do let me know, okay?
All right, sure, sir.
Good. Dr. Jason, are you able to see my screen now?
Yeah, it's clear.
Okay. So today's topic or today's talk is slightly different from our conventional free sessions because I was getting multiple questions and multiple messages from the PACES candidates that how to deal with this PACES 23 and exactly what it is all about. So today's talk will be more about the clinical consultation, and I will tell you exactly what they are changing, and I will try my level best to guide you how to deal with those challenges. Remember that this PACES 23, this term might be relatively a new term, but this pattern was already coined back in 2019. So it was in the process, or it was in, you can say, the record of RCP. They were about to implement that pattern back in 2019 or might be 2020. But of course, there was the COVID, and after the COVID, the things were quite changed. So they have a slightly delayed its implementation. Now, we will divide the candidates in two parts. One, candidates are those who are already preparing for their PACES examination, and they are already or have already appeared in the PACES before. Second type of candidates are those who have never appeared in the PACES, or might be they have recently cleared their MRCP Part 2, and they are really looking for some study material, or might be they need some guidance. Third type of candidates are those who are not PACES candidates, might be they are appearing for MRCPI clinical examination, or might be even their local examinations like DM in India, or might be Arab board, or might be FCPS medicine in Pakistan as well as in Bangladesh. So this presentation is really helpful and really relevant to all these three types of candidates. Dr. Jason, my voice is clear?
Yes, clear, sir.
Remember that why they are bringing this change, what is the need, and why everything they are changing, or is this the everything, or might be only the some aspects of PACES. Remember that the new change, when it is coming, and especially from the RCP, it is backed by evidence, it is backed by studies, it is backed by some feedback, not only from the examiners but also from the candidates. Every new change is trying to make you a very good, very refined, and very quite judgmental clinician. It is really not there to make you afraid, or might be to bring more difficulties for you. If you are asking my personal opinion on this new pattern of the PACES, which we are about to discuss, I will in short tell you that this pattern is really relatively easy. Easy not only for the examiner to evaluate a candidate, but also for the candidate. He is or she is having more time to show to examiner that really they are up to the mark. Secondly, this new pattern is more realistic. They are giving you more time to evaluate the patient, and somewhere they are decreasing the time, which was totally unnecessary. Remember that all these postgraduate exams are in continuous scrutiny. They have been evaluated by the relevant competent authorities, and time to time they are bringing the change. Now, the thing is how to adopt with that. The thing is, I pray and I wish that all my candidates pass in their second diet, this diet which is going on. Unfortunately, say for example, if you are not passing and you have to appear in this PACES23 pattern, now I will teach you how you will modify your studies and how you will be very skillful also in this new pattern. So remember that this clinical consultation, number one, it has been changed, and also one other station that is called clinical communication is slightly changed. If you are paying attention and if you are really vigilant listener, I will explain to you that these changes are really subtle, and these changes are not that much significant, which can destroy your preparation or which can give some hardships to you. Rather, they are there to make you more comfortable, more easy, and more you can say more clinically strong when you are performing your each case. Dr. Jason, my voice, everything is clear?
Yes, clear.
Good. Anytime my voice is getting low, please do let me know.
All right.
So let's start our presentation now. What is this, and what I am writing on your screen? This has been taken from www.mrcpuk.com website. That's your official website, and it states that the clinical consultation, it is basically 220 minutes clinical consultation, will assess candidate across all 7 skills in a realistic integrated manner. The 2 words are really important over there. Number 1 is all 7 clinical skills. So skills tested in your clinical consultation will be exactly like you were doing in station 5. Secondly, it is more realistic. Why more realistic? Because they are giving you more time, and I will explain to you in the next point. Now the candidates will be having 15 minutes to take a structured history. The word important over here is structured history. They have changed the word from the focused history to the structured history. Now this is a new change. Structured history. Please focus on the word structured history. Examine the patient, explain the likely diagnosis and management, and address any questions or concerns if there are any. So the important point over here is 15 minutes rather than 8 minutes. So you will be having 15 minutes rather than having 8 minutes in your station 5 previously, and you have to take structured history, not a focused history. Examine the patient, explain the likely diagnosis, management, and address any concerns, and you people are already doing that. There will be 5-minute questions and answer section with the examiners, that is your viva. So what we are getting in a nutshell and how to summarize what they are writing. If you are a newer to PACES, or might be you are not knowing exactly how this clinical consultation, which was previously called as brief clinical consultation work, let me explain to you. So basically what is happening or what will happen, that you will be given a scenario, you will read the scenario like you are doing before, you will enter the examination hall. You will be having 15 minutes with your patient. Nobody will interrupt you, whether you are taking the history before or you are examining the patient first. You will be having 15 minutes. After 15 minutes, there will be bell and you have to answer the questions of the examiner. But before ending this scenario or before concluding this scenario, you have to manage the patient concerns as you are already doing and also explain the management plan to him or her. So what are the changes? If you are listening to me very keenly, number one, that they are making it more easier for you, that previously you were having only 8 minutes. Right now you are having 15 minutes with your patient and you can easily take a structured history as well as a good examination. Second, the word structured, and I will explain to you in a meanwhile what is structured history. Everything other things are same. Now what was happening in your PACES exam, that the station 5 was the really pressurized station. You will be having 18 minutes already and you have to take the history examine. It was creating sometime really, you can say, a quite stress on you, and sometimes you are missing important things and you were unable to reach the diagnosis. So the point is that now it is more easier for you, more realistic for you, you will be given more time. So say for example you are running on the wrong track, or might be you are missing something, now you are having 15 minutes to correct yourself, to gather the clues, to organize yourself, to reorganize yourself, and to build the findings block to reach the diagnosis. Dr. Jason, my voice is clear?
Yes, clear, sir.
Just a second, please. Okay, Dr. Jason, I am again sharing my screen. Are you able to see my screen?
Yes, it's clear.
Okay. So basically, I am talking with Dr. Jason because his mic is open. I am talking with all the listeners right now. So I am talking with everybody, and you should pay the attention what I am explaining to you, so that this apprehension the candidates are having, that what will happen, what will happen, what will happen, PACES 23, it will reduce your anxiety, and also I will teach you how to approach it and how to modify yourself. Now this is a new carousel and you can see that there is slight changes. Bear with me, pay the attention. If you are seeing right now, the station 1 is slightly changed. Previously there was abdomen and now it is respiratory plus communication. Secondly, this clinical consultation and the station 2 history is now removed. In the station 3, same, which is totally same, CVS and your neurology, and then you are having station 4, that is clinical communication with abdomen, and then is consultation again. So you are already understanding how places work. Right now I will just tell you the changes. So first change they are bringing is no more station 5. Number 2, no more station 2. Rather, in place of them, they are giving you 2 consultation in which you have to take the medical history and examine the patient, manage the concerns in 15 minutes. 15 minutes each, 15 minutes, 15 minutes. Secondly, instead of 14 minutes of clinical communication followed by the viva, the station 4, now they are changing it in 2 clinical consultations, sorry, 2 clinical communications, and it is really easy for you now. I will tell you why. Number 1, no viva. Number 1, no viva, no viva. after these brief communications. Secondly, the good thing about is that you will be wholly solely over there, and you will be, in charge of that station. Like how? Say, for example, the scenario is that the patient is having MS, multiple sclerosis, and you are talking to the dad to explain what's wrong with this daughter. Now you will be talking, and examiner will be observing you. Just what they will observe, they will observe your body language, the way you're communicating, the way you're answering the concerns, the way you are counseling your surrogate. In the end, they will just mark you finish. Of course, this clinical communication, we will be having a separate lecture on that, but right now we are focused on this station 5 and station 2, that is 2 clinical consultations. So if you are with me and if you are listening to me, you will be agreeing with me that now it is relatively easy and more chances for you to pass. Why? Because more time in station 5, that is brief clinical consultation, now 2 consultation, more time. 8 minutes, no more 8 minutes, rather now they are 15 minutes. Then no more viva in the end of clinical communication. Okay, so you will just have to communicate, you will just have to interact with the patient. The surrogate examiner will just look into the matter whether you are covering all aspect of each counseling or not. And we have discussed multiple times in our free session, our courses and others, how to counsel for the disease, how to counsel for each management option, how to do genetic counseling, how to rectify medical error, how to approach the scenario in which the patient is angry. So we have discussed multiple scenarios. So now they will be looking for that whether you are able to incorporate the important high yield assorted information in that 10 minutes or not. Dr. Jason, everything is clear? My voice is clear?
Yes, clear, sir.
Good, thank you. Now, what is the importance of this clinical consultation? You are having these two clinical consultation, how they are impacting you in your PACES, how they can, make you a push towards your failure or make a push towards your path. I am using the word push. Why? Because there are some reasons that these 2 clinical consultations are extremely important in your whole PACES carousel. I'm explaining to you. Now, there are some points I'm explaining to you. 1/3 of total marks of PACES. These clinical consultation together constitute 1/3 of your PACES marks. So say, for example, if a candidate is performing very well in these 2 clinical consultation, there are really high chances to pass. But if he or she is performing poor in these 2 clinical consultation, it means that 1/3 of the PACES has been gone out of your hand. So you mean to say that you have to focus more on this portion. I'm not saying to ignore other stations, but yes, this is a major chunk. This is a major portion of your PACES, 1/3 of your marks. Now, the second point is they are testing, these clinical consultation are testing all clinical skills. There are 7 skills in the PACES. So they are testing your all clinical skills, starting from the clinical judgment, ending at the clinical finding, clinical communication, managing patient concerns, maintaining patient welfare, then clinical examination. They are testing everything. So it is really important. Then this is simulating a real clinical encounter. How you in your OPDs, anywhere you're working, might be in Pakistan, India, Middle East, UK, at least you have been given almost 10 to 15 minutes with your patient. So it will also improve your outpatient skills, outpatient department skills. It will teach you exactly in the shortest possible time how you will be able to evaluate a patient, reach a diagnosis, and even formulate a good investigation and management plan. So this clinical consultation is more realistic. It is teaching you more real approach and the pressure effect, the time effect, which was just 8 minutes before, is now improved. It is now 15 minutes. Fourth point is they are testing you on wide variety of internal medicine topics. So almost each and every topic or any topic in your internal medicine can appear in clinical consultation station. So you should be very ready. And of course, when you are preparing for it and when you are, approaching it, of course, you are learning a lot. And of course, it is improving your clinical knowledge as well as a judgment. Dr. Jason, the voice is clear?
Clear.
Good. Now, how to do it perfectly? This is really important. What exactly they want from you? What exactly you have to deliver? This is very important. In all the courses, I am repeatedly telling my candidates that remember this example. If you are remembering this example, inshallah, hopefully you will never fail your PACES. See, say for example, you are having might be postgraduate degree in your country, you are having, you have read Harrison, Davidson, Praveen Kumar, might be Oxford, all the books. But is this necessary? And do you think that it will be enough? Nobody can answer. But one thing I can answer is by this example. I'm always giving this example. Might be people are now bored from this example. Say, for example, you are a chef and you like spicy food. You love spicy food and you know how to make a good spicy food. If you are opening up your restaurant in the area where people doesn't like spicy food, trust me, you will fail. Nobody will come to your restaurant, even if your food is really good. Say, for example, you are a chef and you like less spicy food, you like mild food, and you are opening up your restaurant in the area where people like spicy food, your restaurant will be a big failure. You should not complain then. So in order to be successful chef or might be a good businessman, you need to stimulate the taste buds of your clients. You need to stimulate the taste buds in a way that they should come back in your restaurant again and again. Similar is the case with the PACES. If you are able to satisfy the examiner, if you are able to provide them exactly what RCP requires from you and exactly what approach they require from you, you will be successful. Remember, PACES, MRCP UK PACES examination as well as MRCP I clinical exam is not a local exam. These exams are the international exam in which the candidates all around the globe are appearing. So they need to standardize the system. They need to have some formula to evaluate the candidates so that everybody should get the justice. So first thing is to know exactly what they require. And if we are able to give them, inshallah, there is no point that we will fail. Or every candidate will pass. Now, how to do it perfectly? Number one is you are sitting outside. You have been given a scenario, any scenario, patient name, patient age, history, short history, past history might be, some examination finding might be, some lab workup might be. Now you should make a roadmap. What are the possibilities? Patient with the dizziness, patient with the chest pain, patient might be with the hearing loss. What are the possibilities based on the scenario which have been given to you on the available data? This is very important. And your mind should work like a supercomputer when you are sitting outside. You should write down or jot down all the differentials on the paper. Now, the second point is adequate control on your nerves. This is all the nerve game. Remember, this is all or none. If you are losing confidence, if you're shaky, remember that it is not only creating a bad impact on your examiner, but also it will derail you, might be it will detract you from your track towards your success, that is your diagnosis. So you should be very confident. You should be confident that I have tried my level best, I have learned something, and I know how to approach each symptomatology or each disease. Then the confidence start. They are looking your confidence. They are handing over the NHS to you. They are trusting on you. They are making you rudge over there. So they need to know exactly how much confident you are, whether you are able to run a ward under you or you are not up to the mark. So confidence is really important. But I'm not using the word overconfidence. Overconfidence means that might be examiner is giving you some clue and you are so super confident that you are not picking that clue. You should be confident, not overconfident. In the confident, I mean not only your body language, not only your tone of voice, but also the way you are communicating with your examiner as well as your patient. Then you have to build the case. Say, for example, patient is having headache. Say, for example, patient is having blurring of the vision. Say, for example, patient is having acromegaly, might be. You are seeing the acromegaly. Now, you should know how to build a case, how to carry the case. What I am always saying to my candidates, you should be bothered about. Number one, the causation of your diagnosis. Say, for example, you are dealing with the CLD, simple CLD case. You should be bothered what is the cause of CLD in this patient. Second, you should be bothered what clinical features of CLD you are getting in this patient. Thirdly, you should be bothered that what are the clinical complications of your CLD which you're getting in this patient. Then, of course, the association, like you know very well, this lichen planus thing and this cryoglobulinemias are associated with that. So everything is important. You have to have very holistic approach to cover up your each scenario. Then complete but to the point history. What means by complete, what I mean by complete history, I will be in a better position to explain to you in the next slide. Thorough but relevant examination. What I mean by that. Say, for example, you are examining the patient and of course you are having a less time for the examination. So you have to choose what to examine and what not to examine. What is the high yield step which will bring you towards your diagnosis and which step is quite low yield. Dr. Jason, just give me a second, please. Sorry, I'm back. Dr. Jason, are you with me?
Yeah, yes.
My voice is clear and loud to everybody?
Yep, clear.
Okay, good. Now, the next step is managing rather merely asking the concerns. I am using the word managing. I'm not using the word just asking. Please focus over there. This is a big misunderstanding or might be underestimation by the PACES candidates. The word used over there is the manage, not the ask. If you're asking the concern, you are asking all the concerns, but you are not managing the concerns, then it will be relatively difficult for you to pass this skill. You have to manage, you have to give the answer, you have to provide the solution, not just, sir, what are your concerns? Okay, no problem. I will be in a better position to answer this after your examination and after your investigation and all that stuff and my CT scan. No, you have to manage. Explaining management plan to the patient, and I will discuss with you how to explain management plan in a shortest possible time. This is the outline. This is the way to carry this case. This is the way to be a very good and distinguished PACES candidate in your center. Now let's move forward. Next is the time management, because this was really a challenging thing previously in our station 5 that the candidates were struggling with the time management. But what I personally believe is that now this concern of the candidates has been resolved. They are having more time now. They're having total 15 minutes with the patient. So we are having a scheme and we are dividing the time in the following headings, under following heading. So first is the history taking, and I am dedicating 8 minutes to this history taking part. Now remember, RCP is allowing you to might be, you can examine the patient first, take the history afterward, or take the history first and examine the patient afterward. Also, they will not stop you if you are might be asking the concerns in between. But you know, the PACES is highly pressurized exam. Remember this. This is the exam. You are under catecholamine rush. Your body is filled, rather boiling with the catecholamines. You are having tachycardia, sweating, tremors, stress. So if we are not following any path, or if we are not catching a train, we will miss the destination. So we should have some plan. We should have some pattern. We should have some, approach so that we must not miss anything. What is happening when we are doing our routine courses, one-to-one sessions, and the candidate is reaching a diagnosis? He is really perfect and he knowing that how to read the diagnosis, but sadly, very sadly, he is missing family history. He is missing social history. So what is happening that you will lose the marks in in those portions. Now I am going back and again I am fourth time reminding you one thing. Remember this word, structured, structured. And now I will explain to you how. Remember that history taking we have already discussed, and my history taking skeleton is already there on the YouTube. If you people have not listened to it, you can listen to it. It's totally free for your help, and you can listen to it as many times as you can. And of course, I will not go in the detail of history taking over there, but I will just enumerate, or might be I'm talking with you about the headings of the history taking, which you have to do. About how to take the history, what exactly they require you from the history, how to approach the history. That station to history taking class will really help you. It is already there on my YouTube channel. So first is the introduction. You're entering in the room, you should be quite confident and you should introduce yourself, the patient, and you should adequately take the consent that, sir, I am over here to talk about your health condition and I have to examine you if this is okay with you. This is must. Consent is must. Then presenting complaint. Why this patient is over there in your ward today or might be in OPD. Then you have to explore that presenting complaint, and we have done multiple lectures on that. We are having free sessions on that on the YouTube, and it has been explained very well how to evaluate each presenting complaint. Each and every complaint has its own approach. Say for example headache, say for example blurring of the vision, say for example swelling, say for example vomitings, say for example lethargy, say for example memory problem. We are discussing multiple things. Then the general questions. What are the general questions? They are basically the bullets in your station, in your you can say case, and they are really helpful in bringing you more close to your what you say towards your diagnosis. What are those questions? I will briefly tell you that we will move forward, like lumps and bumps, any weight changes, any weather preferences, any increased in body temperature, any bony pains, any joint pains, any rash, spots, or pigmentation anywhere in the body, any excessive sweating, any fatigue. So these are the general questions, including diet and appetite, which we are mostly asking. So what I mean to say is that this is really important to ask all these general questions, and they are of course explained. We have explained them well in his technical class. Then the past history, if he is suffering from any condition in the past, or might be is having some surgical or medical history. Then how well the patient is having a good control. Let's say, for example, is diabetic, is hypertensive. How is the control on those conditions, and also whether he is in a regular follow-up of the doctors regarding those chronic illnesses, and also whether he is taking any medication for that or not. Then allergies, food allergies. Uh, any external allergies, any medication allergies, very important. And of course, the medication history. This part, the medication history, I am marking it over there with the pointer. This part is really weaker of the PACES candidates. And I am always focusing on it, that because multiple time the diagnosis lies over there. So what is the history checking about medication history? I will not go in the detail because this is totally out of the context of today's talk. But yes, briefly, I will summarize what happens that the candidate in the courses are asking which medication you are taking. Finish. No, this is not the history. Number one, sir, can you please show me your medication list? Number two, if he is showing your medication list, it is really not necessary that he is taking it. So second question, sir, are you compliant to that list or not? Third question is, are you taking any other medication other than this list? Might be herbal, might be supplements, might be over the counter. Third question will be, sir, any recent stoppage of any medication before the onset of these symptoms? Might be a patient is having right now pulmonary fibrosis, patient of RA. He is showing you the medication list. Methotrexate is not including it in it. But you're not asking any medication before the onset of these symptoms. So might be he was using methotrexate for years and years. Now he has developed lung fibrosis. So ask any stoppage of any medication before the onset of these symptoms. Then the next question should be any start of any medication before the onset of these symptoms. You know very well your beta blockers are notorious to cause exacerbate asthma. Your ACE inhibitors are notorious to cause orthostatic hypotension or might be dry cough. So it is really important. I'm not using the word any recent start or any recent stop. I am using the word any start of any medication or stoppage of any medication before the onset of these symptoms. Why? Because you need a temporal relationship with that stimulus. Then you have to ask any possible side effects or any adverse effects of these medications. Then you have to ask the family history of similar problems, family history of any chronic disease, family history of might be allergies, family history, any disease runs in the family, any cancers, but only if it is pertinent. Then socioeconomic history. In socioeconomic history, we have discussed multiple times in our sessions, free session courses. The mnemonic is your brother Sajid loves tea. What is this? As for smoking, how many sticks per day and for how long? Alcohol, how many units per week, or any previous history of alcohol intake. If you are suspecting that might be my diagnosis is linked with alcohol. Any job, including the previous jobs, especially in the cases of pulmonology. I for illicit drugs. So with which route you are taking, which drug you are taking, if you are taking in the IV form, are you sharing the needles or not? Do not label the patient as having HIV just because he is injecting the drugs. Might be he's not doing the needle sharing. This is very important. Then Sajid ID, D for driving, whether he's driving or not, because sometimes you have to inform DVLA. Last is traveling. Traveling history is also quite tricky and candidates are underestimating it. Number one, where he was traveling. Number two, whether he is completing the vaccinations and prophylaxis or not. Number three, which sort of activities were there. Number four, where he was staying. In the hotel might be, or might be a local area. Then which sort of food he was taking, which sort of water he was taking. Then the important thing about is that whether any visit to lakes or caves, you know very well your fungal infections, your friend giardia is there, and your tick bites and insect bites are quite common in those areas. Ultimately, you have to be very vigilant exactly where he is visiting. Might be to tropical countries, tropical diseases are common. Might be some countries are having their own pattern of the diseases. The last is, then you have to conclude the session, sorry, the history by asking systemic inquiry. Before I go ahead, 2 points I am missing. Number one is the history, the obs gynae history. In the case of females, you are asking 4 P's. One P is how are your periods? Second P is any any pregnancy or any chance of the pregnancy. Third P is, are you taking any pills currently? Pills mean the contraceptive pills. Fourth is any postpartum complication. Your pregnancy was eventful or it was totally uneventful. Might be he's developing some complications, might be some bleeding, something like that after the pregnancy. In the case of females, you need to ask this also. Another question which I am missing over there, but I am deliberately missing it, sexual history, because it is not always necessary. You will ask this or explore this if it is really required. That is like, are you in a long-term relationship? Like, are you married? In a long-term relationship? Then any casual partners, or if you're suspecting highly that might be it is STD, so very politely, in a non-judgmental way, you can even ask about sexual orientation, but this is really a sensitive question. Going to the last point, the number 9 point is systemic inquiry. You have to inquire about the system, the symptom of each system. Say, for example, right now, you were dealing with a pulmonology case. So now in the systemic inquiry, you will ask or formulate some questions which are quite high yield of GI, of nephrology, of neurology, of endocrinology, or might be cardiology. And all these questions have already discussed in much detail in our history taking class, the station to present in on my YouTube channel. So this is the scheme to go ahead, but you have the 8 minutes time to incorporate everything. Now, where you can save the time, this is the point. This 9 number point, sorry, this 9 number point, you can save your time over there by doing a systemic inquiry in quite intelligent way. Dr. Justin, everything is clear? Voice is clear?
Yes, clear, sir.
Okay, good. Thank you. Now, the next step is the examination. Now, over here, nobody is stopping you. You can go towards the examination even before this point. That is point number 5, the past history. But my recommendation is, or my teaching experience states that, or my, you can say, the humble suggestion to you is that you should first complete your history, then jump towards the examination. What I am seeing in the courses, or what we are learning from the candidate, is that if the candidate is missing the history, might be he is stopping the history over there, might be, and then jumping towards examination, he is having not much time to return back to the history, and he is missing all these point number 6, 7, 8, 9, ultimately losing the marks. Yes, during the examination, if you're finding something or something new, then you can ask the questions pertinent to that clinical finding. It's time to move towards the examination, and we are dedicating 5 minutes to examination. And I think it is more than sufficient because you people are already practicing it to complete it in 6 minutes in your station 1 and 3. Also, this is not a complete examination. This is targeted examination. How I am dividing it? I'm dividing it in number one, careful strategy, omit unnecessary steps, carefully choose high yield methodology, and offer leftover steps. First, I will explain to you first 3 points, then I will go towards the point number 4. See, you are playing or you are showing your skills in a timed manner. You are in a time constraints, so nobody is bothered how well you can examine the patient, but what exactly they want you is that how well you are performing or you are playing in a pressurized timed mode. So, number one, you should know exactly what to examine and what to omit. I give you example. Say, for example, you are talking about pulmonary fibrosis. Might be you are talking about bronchiectasis. So, what are the high yield points? Of course, if you're talking about pulmonary fibrosis, we will be bothered, number one, about tracheal shift, because if this is unilateral, specifically apical fibrosis, it will have a traction effect. It will pull the trachea towards the lesion site. So there will be a finding. But what else can be important? I'm just giving the example. I'm not going in the detail of that case. I'm just giving the example. Might be auscultation will be very important. Why? We will get fine and inspiratory crackles or crepitations. But say, for example, you are wasting your time in more in checking the chest expansion. If you can save your time over there, it will be more good for you. Say, for example, you are wasting time in percussion. Might be you can get something, but this will be really a low yield step. So you need to be very vigilant that exactly what I should perform and what I should omit. Say, for example, I give another example. You are dealing with the case of dermatomyositis. You are checking or offering the proximal myopathy checking. You are seeing the rash. You are auscultating the lungs now for lung fibrosis. But the good candidate will ask the same scheme, will work on the same scheme, which states that I will be bothered about my disease associations as well as complication. What are the association? Might be lung CA. I will palpate the lymph nodes, especially there is history of weight loss. Then might be it is associated, that is the lung fibrosis is associated with something called right heart failure or pulmonary hypertension. So what I have to check? I have to check number one, dilated heart, that the shifted apex beat. I will be interested in checking left cranial heave. I will be very interested in palpating the palpable P2 along with listening to P2 as well as S3, the sound of heart failure. Then I will be very interested in checking JVP along with pedal edema. Now this is making sense. So rather than going for chest expansion, other than going for percussion, these steps will be more high yield to bring you more closer towards your unified diagnosis. This is just an example. Of course, this changes with case to case basis. I am just giving you example. Now, in the end, what you have to do, you have to offer leftover steps. Say, for example, you wanted to check for might be lymphadenopathy, and your time is less now. At least, please offer to examiner. At least examiner should listen that the candidate is really interested in checking for lymphadenopathy, and he is knowing that it is important in this case. Say, for example, you are knowing that might be this is a case of might be Paget disease linked to hearing loss, might be CP angle tumor linked to hearing loss. At least you don't have the time offer Rennie and Weber test to examiner. Say, for example, you are dealing with a condition in which it is really important to do DRE, digital rectal examination, or might be genitalia examination. Now, at least you should offer this to your examiner. If you're not offering, it means that you are even not knowing or not having their importance, that they are pertinent to this particular case. Just a second, please. Dr. Jason, and my voice is clear and loud.
Yes, clear.
Okay, thank you, Dr. Jason. Now, let's move forward. We have covered this examination part. Now it's time to manage the concerns. Another mistake, what we are noting and feeling in our courses, the routine one-to-one session, the courses, is that the candidates are sometimes asking about the concerns in the midway. Like, take this example. I am teaching you something, okay? Then we will perform a case. It makes sense that I should ask your concerns or questions in the end. If I am asking the questions or concerns, it means that I have finished my narration. So it is sometimes creating a bad impression on the examiner that you are left with the history, you are left with the examination, and you are managing the patient concerns, and suddenly you are remembering the things, and you again started from the history, and you're again exploring the examination. So try to finish everything, then go towards managing concerns. Now we are giving 1.5 minutes, 1 minute and 30 seconds to managing concerns. And I personally believe that it is more than sufficient, but it is important how you are managing the concerns. And I will teach you in detail, and also I will teach you what are the common mistakes made by the candidates in the PACES exam, in the routine courses and one-to-one sessions. Now, first is to ask the concerns. So, do you have any concerns? Now you have to manage them in shortest possible duration. Now, say for example, I ask the patient asking me the concern. So, do you think that this condition is curable? Now, there are two ways to answer this concern. One way is, sir, you are having shortness of breath, and also you are telling me that you got hemoptysis. Also, sir, you are losing weight. Plus, on examination, there's lymphadenopathy, and you are having heavy smoking history. And also, your mom was diagnosed as a case of lung cancer in the early age. What I think is that you're having lung cancer, and I'm sorry that this is not curable. Or say, for example, surrogate is asking you, sir, are you admitting me in the hospital or will you manage me in the OPD basis? Sir, you are having shortness of breath and also you're having fever. And I can see that you're having rigors and chills and your CRP is quite high, labs are quite deranged. So I decided to admit you in the hospital. This is one way to answer the concern. Now I'm telling you the other way, the more quickest, shortest possible way to answer the concerns, because there are sometimes more than 6 concerns associated with each case. First concern, so do you think that this is curable? I have taken your history and examination, and according to that, I believe that this is not curable, but I will be in a better position to answer that after your relevant investigations. Finish. Are you going to admit me in the hospital or managing me in the OPD? According to your narration and your examination finding, what I believe is that you need admission in our ward today. Finish. Why? Because patient will be having sometime more than 6 concerns. And if you're wasting too much time on one concern, you will be left with multiple concerns in the end, and what you will get in your feedback that you are even not borderline, rather unsatisfactory in managing patient concerns. Respectable, sharp, quickest possible way to answer the concerns. Remember, also, this word is wrong, answer the concern. This is wrong word. Best word is manage the concern. I give you example. What is the management? I want to get back to home. I do not want to get admitted in this hospital. So what's the reason? There's too much light and noise in your ward. So don't worry, I will immediately talk to our ward manager at the end of this consultation. Might be we will be able to provide you some isolated space. I still do not want to get admitted in your ward. Why? Because I do not like the food over there. So don't worry, I will immediately talk to our kitchen manager to see how we can provide you the meal according to your wishes. Any other concerns, sir? Finish. Manage the concerns, not just ask the concerns. I am having needle phobia. Manage it. I am having social phobia. Manage it. It is not about asking the concerns or answering the concerns. It is about managing the concerns. Dr. Jason, voice is clear?
Yes, it's clear.
Good. Now, last 30 seconds, I am giving to the explanation of management plan. Why just 30 seconds? You can ask me. Remember, examiners are there. Examiners are having 5 minutes to evaluate you, to ask you clinical findings, to ask investigations from you, to ask your management plan. They know how to evaluate you. They know how to test you. Right now, in the last 30 seconds, what you have to do, say, for example, the patient is having, might be, what I can give you the example. Say, for example, pneumonia with low saturation. So simply say that, sir, likely you're having a pneumonia with low oxygen levels in your blood. We are about to admit you in our hospital. We'll start you on the oxygen, also on your appropriate antibiotics. Along with that, we will run some tests and some imaging so that we should manage you adequately. Finish. Say, for example, patient is having stroke. You can say that. And he is an old stroke patient. Might be old stroke patient, not a recent stroke. You can say that. So you are having a stroke and you're having difficulty in coping up with the daily activities. Immediately at the end of this meeting, I'm talking with the occupational health physician to help you in this regard. And also, I am bothered about your social support, and I will make some changes through occupational therapist in your surroundings so that you should easily cope up. Along with that, I will recommend you adequate physiotherapy with the medications. Finish. Yes, detailed questions will be asked by the examiners. Okay. Now, I think I should have a break of might be 1 minute, 2 minutes to give some rest to my throat. Then we will be having a very high yield clinical consultation, and Dr. Jason will perform in front of you, and I will teach you what are now the practical implication of what I was teaching. Dr. Jason will perform the case, and of course, at the end of this case, I will give the intensive, detailed feedback about the performance. Just give me a little break of 1 minute, then we will proceed. I think we can start now. I'm okay. Dr. Jason, I am giving you the scenario, and also you will be given some clinical findings along with that. Are you ready?
Yeah, yes, sir.
Good. So I am sharing with you your scenario. Have a look, then get back to me. You are having 2 minutes to read the scenario, make your notes, and you will be having then 15 minutes with your patient and 5 minutes viva. Your time starts now for 2 minutes to prepare this case. Dr. Jason, are you ready?
Can you give me 30 seconds more?
No problem. Take your time, please. Dr. Jason, are you ready?
Yeah, yes.
Good. So I am starting your timer. You have a total 15 minutes, and I will prompt you around about 13 minutes. So I am giving you a timer, and your time starts now.
All right, good morning. I'm Dr. Jason, one of the medical officer in this clinic. Am I speaking to Mr. Zia, 55 years old of age?
I am Zia, and I am 55 years of age.
All right, sure. Hi, Mr. Zia. So today I'm going to ask you some questions and also to examine you along the way. Is it okay?
Fully okay with me. Go ahead, please.
All right, Mr. Zia, so I understand that you came in because of a difficulty in swallowing. Can you tell me more about this?
I am having difficulty in swallowing, and I am really suffering, and I really need your help, please.
All right, may I know how long you've been having this difficulty in swallowing?
This is happening might be for the last 3 months, and it is slightly getting progressive.
All right, so for the difficulty in swallowing, is it like started off with solid food or liquid food?
It is almost with the both.
All right, and May I know where does the foot stuck?
It stuck in the mid of my chest and the patient is touching mid-thoracic area.
All right, sure. So for the difficulty in swallowing, is it associated with pain when swallowing?
No.
All right. And do you have throwing up?
No.
All right. And is there any sores in the mouth?
No.
Right. Do you have any tummy pain?
No tummy pains.
Do you have any like a yellowish discoloration of the skin?
Never, ever.
Do you have a heartburn, burning sensation in the chest?
Yeah, it is happening. It is really happening that whenever I'm taking the meal and after that, it is having a sense of burning in my chest.
All right. Do you feel the acid breath in the mouth?
Not much.
All right. And do you have any loose stool?
No.
Any like constipation?
No.
All right, sure. Do you have any raise in body temperature?
No.
Any weight change?
Yes, I am losing some weight.
All right. May I know how long you've been having this weight loss?
I'm having this weight loss since the start of these symptoms.
For the past 3 months as well.
Yes, exactly.
All right. May I know how much do you lose weight?
I have lost might be 1.5 kilograms of weight over this duration.
All right. Is it intentional or unintentional?
It is totally unintentional.
May I know how's your appetite?
Appetite is good, but of course I am getting terrified to take something because of these symptoms.
All right. And do you have any rash?
No, no rash.
All right. Is there any like skin changes or any red spots or pigmentation?
Yes, I am having red spots on my face.
All right.
You
And
can see my face.
right, sure. And do you feel that your skin become tightened?
Yes, it is happening. It is happening in my fingers.
All right, sure. And do you have any joint pain?
No joint pains.
And do you feel pain in the hand, especially during cold weather?
Yes, it is happening. And I think that it happened, it might be twice.
All right. And do you feel like there's a change in the hand color, the color in your hand as well, especially during
You
cold
are
weather?
really a good doctor. It happened with the pain twice in the last 6 months.
All right, sure. And is there any weather preference?
No weather preferences.
All right. And how's your mood?
Mood is almost good.
All right. And do you notice that you look more pale than before?
No.
All right, sure. And do you have shortness of breath?
No shortness of breath at all.
Do you have chest pain?
No chest pain.
Any racing and pacing of the heart?
No.
Do you have body weakness?
No.
Any body numbness?
No.
Or difficulty in maintaining balance?
Sorry, again ask.
Do you have a difficulty in maintaining balance?
No.
All right, sure. So may I know, do you have any like a known medical condition in the past?
Yes, I have been diagnosed as a case of diabetes.
All right, sure. So are you taking any medication for that?
Now I am on insulin.
All right. And are you complying to the medication?
I try to be always a very good patient.
All right. And do you know your 3 months sugar control?
I am not aware, but they are testing. I think might be or getting results in some time.
All right, sure. And do you have any like a frothy urine? Hello? Hello? Hello?
No,
Hello, sir, your voice breaking. Hello?
no.
All right, sure. And
Dr.
hello?
Jason, my voice clear? Are you able to listen to me, Dr. Jason?
Yeah, it's a bit like
Hello?
breaking. Hello? Hello, sir?
Okay, now is it clear?
Yeah, now
Candidates,
it's clear.
please give me a feedback. The Zoom chat box, my voice is clear or not?
Yeah, now it's
I
clear,
need a
sir.
feedback in the Zoom chat box. Okay, is it clear now? Good, no problem. I will give you some extra time. No issue at all. So you will
All right,
be
sure.
given 1 minute extra and you can see the scenario now.
All
Go
right,
ahead.
all right, do you have any blurring of vision?
No,
All right, sure. And do you have any regular follow-up for your diabetes?
no,
You're not under any follow-up for that.
no,
All right, sure. And do you have any previously any stroke,
no,
any heart disease which was diagnosed previously?
no,
All right, sure. And you do have any allergy to any medication?
yes, I am allergic to penicillins.
All right. And do you have any a surgery or any medical procedure done in the past?
No,
All right. Is there any condition that runs in the family?
yes. My father is having something called cancer in the food pipe. My mom is having something called eclasia. My brother, my sister, she has been diagnosed as the case of globus hystericus.
All right. Sure. And do you smoke, Mr. Jia?
I love smoking.
All right. May I know how long you've been smoking and how many cigarettes you're taking every day?
I am taking more than 30 sticks per day.
All right, sure. So, Mr. Jia, smoking is very injurious to health. So I would like to advise you to stop smoking. And if you're keen, I will refer you to the smoking cessation clinic. Is it okay?
Thank you so much.
All right. Do you drink alcohol?
No,
All right. And may I know what do you do for a living?
I am working as a businessman.
All right. And may I know how does these symptoms actually affecting you?
You can understand well that is really difficult to lead a very normal life because I'm having this sense of stucking something back in the chest. So it is difficult to cope up.
All right, sure. I'm so sorry for that. I'll try to help you after this. Is it okay?
Okay.
All right. And are you married, Mr. Jia?
I'm married.
All right. I'm sorry to ask you a bit sensitive question. Are you on any casual relationship?
No, I'm only married.
All right, sure. And are you taking any a party or recreational drugs?
No,
All right. And do you drive, Mr. Jia?
a lot.
All right, that'll be fine. And do you have any recent travel?
Yes.
All right. May I know that where did you travel recently?
I was traveling to interior Africa.
All right. May I know when was the last time you traveled?
Might be about 4 months back.
All right. And may I know what was the activities you have done in India?
Africa.
Oh,
It
Africa.
was just a camping activity, and we were having a camp for the poor patients out there. And as a businessman, I was looking after those free activities.
All right, sure. All right, and all right, sure. So yeah, I would like to ask a few questions. Do you have any sores in the mouth?
You asked before, no source.
No sores in the mouth. All right, sure. May I examine you, Mr. Jia?
For sure, you can.
All right, so I want to examine Mr. Jia's the hand. Is there
So
any
you
like?
are looking the patient's hand, and these are the Mr. Zia hands.
All right, and so I can see that there's a skin tightening and also ulcers, and also all right, and then I would like to assess, is there any like a pulp or trophy of the fingers at the distal part?
Nothing there.
All right. Also, I would like to examine
2 minutes from now, almost.
Examine the forearms. Is there any like skin tightening? Is it up to the elbow?
No.
All right. Means it's a distal to the elbow.
Yes.
All right. And then I will examine the face. Is there any like a telangiectasia? Like just now I've seen the red spots. And
These
then
are the red spots on the face.
And then I'd like to ask the patient to open the mouth to see is there any like a microstomia?
There is slight microstomia.
All right, and then I will quickly auscultate the lungs from the back.
You are auscultating the lungs from the back, and I will waste your almost 20 seconds because we have to mimic it like a real exam. Chest auscultation, finding the totally normal from behind.
All right, sure. And I would quickly examine the heart. Is there any like loud P2?
So you are examining the heart, focusing on the P2 as well as S3. Heart auscultation is almost totally normal.
All right, sure. So, Mr. Jia, may I know what's your concern?
My concern is, do you think that this condition is curable?
I'm sorry to tell you that I have to examine. I have to run some tests to get the exact diagnosis. But from what the history is telling me, I don't think that this disease is curable.
Do you think that this condition might be running in the family?
I don't think that this disease is running in the family.
Do you think that might be you are pushing me towards camera test?
Yes, I feel that
Time is almost up. Just give me a second. We need a very good summary of your case.
All right, sure. So this is a 55-year-old patient who has underlying diabetes, who is poorly controlled and is currently on insulin. Is having this difficulty in swallowing for the past 3 months. Has difficulty in swallowing for the solid and also the liquid food, and also he's having a heartburn. Besides, he's also having a weight loss of 1.5 kg for the past 3 months, and also having red spots over the face and skin tightening with Raynaud's phenomenon. And there is a family history of cancer, achalasia, and also globus hysterica. And he's a smoker. And for the examination wise, I'm able to my positive findings is that there's a skin tightening over the hands, and also there is superficial ulcers over the dorsal aspect of the hand as well, and there is examination of the face. There's a telangiectasia and so microstomia. However, I could not appreciate any lung fibrosis or any evidence suggestive of copulmonary.
Positive findings. What are your differentials?
My differential diagnosis, this patient is having diffuse cutaneous systemic sclerosis.
Okay.
All right, and
Any other Any other differentials?
Other differential diagnosis can be achalasia.
Okay.
And yeah, that's what I can think of. Esophageal cancer can also be the differential, but usually it will start off with solid and it will progress to liquid.
Okay. How
And
you will thoroughly investigate your patient?
to investigate this patient, I will send for full blood count to look for any anemia, and then also inflammatory markers ESR and CRP, and also renal function tests and electrolytes to rule any like scleroderma renal chloride crisis. Also send for urine analysis to look for any proteinuria. Autoimmune serology, I will send for ANA, anti-centromere, and also anti-SCL70. Yeah, and also I would just do a chest X-ray to rule is there any like fibrotic changes.
Okay.
Yeah. To manage this patient, I think I can treat this patient as an outpatient basis, and then I will educate and counsel patient regarding the disease. And if my investigation suggestive of systemic sclerosis, I will involve a multidisciplinary team approach. I will refer the patient to rheumatologist and also I think gastroenterologist for co-management. For the dysphagia, I will start a patient with the proton pump inhibitors for symptomatic relief, and also a calcium channel blocker like nifedipine or amlodipine. And if not improving, probably like dilatation might be required after that. For the systemic sclerosis, I will treat the patient symptomatically. Like for the Raynaud's phenomenon, calcium channel blocker can be started. And yeah, for the skin tightening, we provide emollients for the patient. And the telangiectasia, pulse dye laser therapy. And
okay, let me give the feedback of your case and let me tell you exactly what are the pitfalls and where you can lose your marks. Okay, are you with me?
Sure.
Remember that might be you people are feeling that now the station 5 is getting easier. Candidate is more confident, more comfortable, and he is in a good control of the case. Now this patient was having something called dysphagia and is a known case of DM. In the lab workup, they're giving ASR slightly raised with HbA1c of 7.6. What is coming in my mind when I'm sitting outside? Anything can come in my mind considering it a case of dysphagia. But the thing is, heavy smoker, weight loss with dysphagia, this was the presenting complaint. Heavy smoker, weight loss with dysphagia, it means that I am dealing might be with some sinister pathology, but the good thing is that the ESR was just slightly raised. It means that we need not only to look for the cancer, but also I am supposed to rule out other uncommon chronic causes. Dr. Jasmine, are you with me?
Yes, sir.
So now, how to start this case? I will ask myself whether this is a pain symptom or a non-pain symptom, and this is non-pain symptom. I will start with OD para. Onset, gradual. Duration, 3 months. Progression, yes, it is progressing. A relieving factor, no relieving factor. And you should strengthen yourself by asking, might be you are doing some manure, might be you are taking more water to let your food down. should ask it. Don't rely just on the question that I am asking and the patient is saying no aggravating or relieving factor. You should ask categorically. Then relieving factor, anything you're doing, an aggravating factor might be any specific food, might be any specific situation which is making it bad. So what we are getting that this patient is having dysphagia for the last 3 months. It is slightly progressive and there are no relieving or aggravating factors. Next, A is really important of OD-para associated symptoms. What can be associated with this dysphagia? Come out of the box. Totally come out of the box. Ask yourself what can be associated with the dysphagia. Okay, might be this is a case of cancer. So I will ask about any hematemesis, any melena. I will ask about any lumps and bumps. Might be this is a case of achalasia, how it started with the food solid or with the liquids also. Remember, neurological dysphagia usually start with the both. Yes, mechanical obstruction like with the stricture or might be with the growth usually start first with the solids, then progress towards the liquids. But here it started both together. Okay. What are the other causes of dysphagia? Might be the patient is having myasthenia. So it will take just 5 seconds to learn myasthenia by asking something called any drooping of the eyelid, or might be anything called fatigue, usually in the evening. What can be associated with the dysphagia? Might be this is iron deficiency anemia from Wilson syndrome. Any problem with your tongue? Anybody told you that you are getting pale than before? Any sense of obstruction which he is getting is linked more with the solids? Okay, might be it is linked with motor neuron disease or might be linked with the stroke. So feel free to ask about any loss of power in any body limb or any neurological symptom. So this is the scheme which we are following, and where we are following in OD-PA-RA, A, associated symptoms. You just don't need any book for that. You need a clinical approach. That this patient is having dysphagia and what are the common causes of dysphagia which you people are commonly seeing in your wards and in OPDs. Oh yes, I was reading somewhere that might be thyroid swelling is linked to dysphagia. So feel free to ask about something called weather preferences, any lump in the neck. Oh yes, I was reading might be heart enlargement can lead to dysphagia. Feel free to ask about orthopnea, PND, SOB, pedal edema. Now what we are left with? We are left with your friend called scleroderma, and this was Dr. Jason, not a diffuse type. This was a really limited type. Clear?
Oh, yes, yeah, limited. Okay, sir.
So I will ask the question, so do you have any skin tightening? And you are asking me, and I'm telling you yes. Now, what was the first mistake made by you? You are covering this mistake, but sometime in the exam, when you are under stress, under catecholamine rush, you are forgetting the questions. So you are getting skin tightening and there's dysphagia. It means that we are dealing with likely stress syndrome. So it's a time to complete all the questions of stress syndrome. What are the questions? C for calcinosis. Sir, do you have any sores on your finger ever? Ever mean even the past history will be covered. Then R for Raynaud phenomena. So did you ever felt that your fingers are changing color or they are feeling pain, especially on the cold exposure? Yes, you're a good doctor. It is happening to me. Specifically ask about the color changes. E for esophageal dysmotility. As for sclerodactyly, you're already asking. T for telangiectasias. Now there's a catch point. Remember, I am always teaching my candidates. Rash will never be covered sorry, red spots, telangiectasias will never be covered with the rash. Pigmentation will never be covered with the rash. Pigmentation will never be covered with the red spots. It is really important for you to ask these three questions simultaneously to be a very good history taker and reaching the diagnosis. Sir, do you have any rash, spots, or pigmentation anywhere in the body? Again, repeating. Sir, do you have any rash, spots, or pigmentation anywhere in the body? Now it will cover your rashes. Now it will cover your pigmentation of Edison. Now it will cover your red spots of telangiectasias. Might be Osler Weber, might be ataxia telangiectasia, might be your friend Crest syndrome. Dr. Jess, is it clear?
Yes, clear, sir.
Good. It's time to move towards might be other association, the complication. If you are thinking, even though it is less associated, lung fibrosis, ask about SOB or Thopnia PND, you can ask. Now it's time to move towards general questions. What are our general questions? Any lumps and bumps? Any fevers? Any changes in the weight? I'm not asking about just weight loss. I am bothered about any weight changes. Why? Because it will cover even your weight gain, even your weight loss. Say, for example, your friend insulinoma. It is coming, it is associated not with the weight loss, sometimes it is coming with the weight gain. Similarly, you have to ask about weather preferences, sweating, bony pains, body aches, fatigue, appetite, diet. Now, when he is taking the history, he is getting a history that the patient is having 1.5 kilogram of the weight loss, and categorically candidate is asking exactly in how much duration you got it, and he is getting it in might be 3 months. Now he is not picking up the cancer diagnosis. Why? Because he is asking himself that is this necessary or is this enough for the patient to get a cancer with just 1.5 kilogram of weight loss? Secondly, he is intelligent enough to even explore the patient diet and appetite. And of course, it is reduced because he's having a fear that might be the diet is getting stuck behind my sternal bone. So you have to attribute it. You have to separate the weight loss of the cancer from the other weight losses. Do not deliberately attribute all the weight losses with the cancer. Yes, it will come in the differentials, but down the list. Coming back to past history, you have to ask about diabetes, since how long he's having diabetes, how well the control is, how was the last 3 monthly sugar levels, along with cholesterol testing. Now you should be bothered, you should screen for any complication of DM. How you will screen? Remember, do not afraid. It will hardly take you 10 seconds to exclude all the complication of diabetes. Like he's asking, so do you ever got any stroke, any chest pain, any froth in waterworks, or might be increase or decrease in your waterworks? He is excluding CKD. Do you have any numbness, tinglings in your hand and feet, excluding peripheral neuropathy? Do you have any pain on the walking, excluding peripheral arterial disease? So you should be very sure that whether I am dealing with any such complication or not. And you are telling to examiner that, see, I'm a safe doctor. I am bothered even about the chronic condition and I'm excluding it. You should be bothered about any regular follow-ups. Are you in the regular follow-ups of your doctors, and how to follow yearly follow-up with the nephro doctor, kidney doctor, yearly follow-up with the foot doctor, podiatrist, yearly follow-up with the eye doctor for retinal and lens examination. Retinal examination for diabetic retinopathy, lens examination for premature development of the cataract. Dr. Jason, my voice is clear and loud?
Yes, it's clear, sir.
Good. Now it's time to go ahead with allergies and medication history. A recent medication, which medication you're taking, then past medication, any stoppage of any medication, any start of any medication before the onset of the symptom. Who knows, might be was taking bisphosphonate, which are leading today with the stricturing there. They are notorious to cause esophageal ulcerations. Very important. Might be he is knowing he is taking something called MRCP or calcium channel blocker, which is leading to exacerbation of the GERD and all related complications. So you should ask. Then the family history, then the social history we have already discussed. Your brother Sajid loves tea, S for smoking, A for alcohol, J for job, I for illicit drug, D for driving, T for travel. Dr. Jason, you're asking me about smoking. I'm saying you that I am taking 30 sticks per day, but you're not asking me since how long. Say, for example, I am taking 30 sticks per day for last might be 2 years, or I am taking 30 sticks per day for might be last 30 years. Do you think it is making any difference?
Yeah, yes, there'll be a difference.
Very important, because you are excluding the cancer. You need more evidence to be very sure that, yes, this is a case of CREST syndrome. Now, there is a challenge. And what I am about to tell you is that this is slightly a difficult thing. Listen to me very carefully. Don't you think that the CREST syndrome patient can get cancer? Don't you think that the patient with the CREST syndrome can get achalasia? Don't you think that the patient with the CREST syndrome might get Plummer-Wilson syndrome? Don't you think that the patient with the CREST syndrome might get esophageal rings? Yes, they can. They are human beings, normal human beings. So we need to exclude all the relevant differentials to label this patient as the case of esophageal dysmotility secondarily to CREST syndrome. And we will be able to do that when we are having a very good history and good examination. Dr. Jason, is it clear?
Yes, it's clear, sir.
Good. It's time to move towards something called systemic inquiry. Say, for example, you want to ask about right now anemia, might be you are bothered about anything you are missing, any GI symptom you are missing, you should exclude all that stuff. Now it's time to go towards examination. So in the examination, I will be bothered about observation charts first, patient vitals, might be anemia I will see, might be lymphadenopathy I'm checking. Ultimately, I'm examining the patient according to the findings. Now, Dr. Jason, I am sharing with you the screen. If you're able to see my screen, please do let me know.
I can't see, sir.
Just a second, just a second,
Yeah.
just a second.
Yeah.
Dr. Jason, I am sharing my screen. Are you able to see it right now?
Yes.
Good. Now, what is this? These are telangiectasias. Sometimes they are appearing like dilated, these arterioles, like you are seeing, and they are highly characteristic. They are appearing like that you are seeing, I hope, and might be they are appearing. This is same finding, like they are dilated arterioles. You are seeing them over there. They are usually around the nasal bridge, or they are appearing like that on the nasal bridge. But sometimes they are also appearing like a red spots, like I was showing you in your case. You can see there are multiple red spots. So first thing, the CREST syndrome T, telangiectasia we are seeing. The next finding over there is calcinosis. You can see that there is calcinosis. Might be it is not present at present in your exam. Might be you are seeing some healed sores like you were seeing in your case. Those calcinosis, those sores, those ulcers were quite healed, but here they are quite active. If you're a keen observer and if you know how to examine, you will agree with me that the index finger of this patient, the both index finger, especially their distal phalanx, is quite resorpted. He is having multiple episodes of dyscalcinosis, multiple episodes of these sores. The distal phalanx is quite resorpted, quite short, quite wasted. This is also the finding over there. So up till now, I am showing you three findings: distal resorption of the distal phalanx, then calcinosis, then something called skin tightness. This is the skin tightness which I am sharing with you. It is not that much clear over there, but it was quite clear in your that picture which I was showing you in your case. So another finding, telangiectasias, we have already seen. Now, what is this? This is Raynaud phenomena. Of course, this will not be present in your exam, but you have to explore the history of it in the past. Even this history might not be present in examination or exam because might this patient is having healed sores. So you should ask about that in the past. And what I personally believe is that I should again show you people that case because it is quite pertinent, and you people should what you say, see it again. So, Dr. Jason, are you able to see my screen now?
Yes.
Yes. So we are particularly taking or discussing that case now, and I was showing this picture to you people that there is healed sores. These are healed sores. If you are a keen observer, you will see that these are healed. The fibrosed basically. So these are fibrosed, and there is very good skin tightening, the shiny skin visible on the fingers. Similarly, these red spots over there on the nasal bridge, you can see on even on the cheeks. Now, let's get back and let's discuss what we are missing. And the last thing is esophageal dysmotility, which we are getting in this case. Now, what you need to examine, we have already examined the anemia. We have already examined something called lumps and bump lymphadenopathy. If you are bothered about might be ptosis, you can examine it. Might be proximal myopathy, you can examine it. But of course, it should be very, very available or very evident in your history also. You have tested for lungs, that's a good thing. You are testing for loud P2, for pulmonary hypertension, for you are testing for left breast-renal heave, checking JVP, pulmonary hypertension. That's a good thing, and you can. But yes, it is less associated with the CREST syndrome than the others form. Now, coming back to investigation, examiner is bothered. Examiner is asking you how you will investigate Mr. Zia. Examiner question is not the investigation of CREST syndrome. He's asking you how you will investigate Mr. Zia. So number one, I need to go ahead with CBC, complete blood count. Might be I'm getting anemia. There's anemia, especially iron deficiency, or might be any deficiency. I will characterize it with the help of MCV, and might be I am ordering or requesting something called vitamin B12, folic acid, irons. Ultimately, peripheral film to look for the RBC's morphology, and ultimately, I will be really interested in doing the workup of CREST syndrome. If you're talking about the blood workup, of course, 3 antibodies are really important over there. One is your best friend ANA. Second is anti-centromere antibodies, very pertinent to CREST syndrome. The third one is SCL70 antibody, which is for diffuse form scleroderma. Still, you are interested in blood investigation. Might be you are going for calcium, levels, but it is usually normal in calcinosis, but you are testing it just to rule out if there is any other cause of hypercalcemia. But usually it is normal in these patients. Raynaud phenomena, it is clear cut with the CREST syndrome, but if you are suspecting might be, according to your case, you want to rule out some secondary pathology, according to the case, might be suspecting peripheral arterial disease, might be you are ruling out with Doppler scan, but it is not routinely done in CREST syndrome. What we are doing, we are getting ANA, we are getting anti-SCL70 antibodies, we are getting anti-centromere antibodies, and we will be interested in might be X-ray that is joint pain, any joint pains. Now, the most specific one over there will be something called endoscopy, upper GI endoscopy, because dysphagia is always a warning shot or warning sign. We need to scope the patient. But remember, investigation with upper GI endoscopy is there to rule out any sinister pathology, but we will be going towards ultimately something called manometry. So Jason, everything is clear?
Yes, it's clear, sir.
Good. Now it's time to move towards management. Management is not that much straightforward. Management is not that much easy. Management is not that you are telling this, goodbye, goodbye. We need to be a very distinguished candidate. We need to show that we know how to adequately manage the patient in 360 degrees in all the aspects. So first is non-pharmacological management. For that non-pharmacological management, patient education, patient counseling, avoidance of the traumas to the fingers, and I need to provide gloves to the patient, especially in the cold. I am teaching him that avoid cold touching, avoid holding ice, avoid exposure to the cold. I am giving proper diet, soft diet to the patient after consultation with my dietitian. I will be very interested in providing the emollients to the patient for these sores as well as tightness of the skin. After doing all that, it's a time then to start with pharmacological management. In the pharmacological management, calcinosis is really difficult to treat, but it is amenable to something called intralesional steroids. Then the second is Raynaud phenomena. For the Raynaud phenomena, I am already telling you non-pharmacological management, but now I can go for calcium channel blocker, nifedipine like, might be I am going towards inoprost or this prostacyclin analogs, might be even topical GTN. For the esophageal dysmotility, the best thing is to start with PPIs, prokinetics. Sometime might be, if indicated, we are going towards dilatation if required endoscopically. Sclerodactyly, it is also difficult to treat, but for that, sometime we are giving, I think, penicillamine and some other drugs, but they are really in the trials. No specific treatment for this sclerodactyly. Ultimately, the last one is telangiectasias, and for telangiectasias, usually we are going for pulsed dye laser therapy. Now, what is this and why we're doing that? Usually we are bothered about these telangiectasias for something called cosmetic purpose. Why cosmetic purpose? Because the patient might be bothered about the look, okay? But for this thing called the telangiectasia, which might appear in the gut or might appear anywhere, we will go ahead with the treatment accordingly. Remember that This patient need holistic management. This patient need MDT, not just including gastroenterologist, not just including only dermatologist, but he need really holistic approach. Dr. Jason, is it clear?
Yes, it's clear, sir.
Good. Now I will give a maximum 5 to 10 minutes question answer session. If anybody is having any questions, do let me know. Any questions?
So for this,
yes, please, Dr. Jason.
yeah, so for this patient, should we like even mention about the diabetes when there's actually lacking of time? The diabetes
I'm
control.
sorry, we need to also tell the diabetic investigation because this patient is not in a regular follow-up. So we need to even mention HbA1c, which has been done. We need to go ahead with fasting lipid profile. We are bothered about renal profile. We are bothered about urine detailed report. We are bothered about relevant investigation of the diabetes, considering also that this patient is not in the regular follow-up of the diabetologist or endocrinologist.
Right, sure.
And
thank
also,
you,
we need to offer the routine follow-ups, which I was already telling you. Any other questions? Any queries, any confusions, any problems, any difficulties, feel free to ask. Okay, if there are no more questions, we should conclude our session, and inshallah, hopefully, we will be also having a class, a session on your clinical communication very soon. Thank you so much for your participations, your time, and your questions. And hopefully, I will be back next week. Have a good night and goodbye.